was really a spectacular talk. I get the opportunity to hear Dr. Ulrich a lot. That was really one of the best talks I've heard about clinical trials, basic clinical trial stuff. So our next speaker is Dr. Michael Fisher, who is also a world expert in care of NF patients in NF clinical trials. He's an associate professor of pediatrics at Children's Hospital of Pennsylvania and also holds a very important role in the Department of Defense Clinical Trials Consortium, which is arguably the biggest clinical trials group doing clinical trials for NF patients. We're very fortunate to have him here to follow up this talk. He's going to give a basic update on types of drugs in clinical trials for NF1 and NF2. And I'll just say that the reason I'm wearing a tie today is I got to match him. You know, we always go back and forth. So welcome, Michael.
Okay, thanks, Scott. Nikki, that was great, and it really makes understanding this talk a lot easier if you understand the basics of clinical trials. So the good news is in the last 10 years, there's really been a tremendous increase in the number of clinical trials done for manifestations of NF. But that, of course, makes it impossible to review all of them. And so what I thought I'd do is focus on the trials from the NF Clinical Trials Consortium so you get a flavor for the types of trials we're doing and the reason we're doing those trials. So the Clinical Trials Consortium was founded in 2007, and really the goals are to develop innovative therapies for children and adults with NF and to implement trials for multiple manifestations of NF to rapidly improve outcomes. And we have done or are doing clinical trials for the following manifestations: plexiform neurofibromas, malignant peripheral nerve sheath tumors, low-grade gliomas, vestibular schwannomas, cognition, and tibial pseudoarthrosis. And I'm going to touch on all of them in this talk. This is truly a collaborative effort. So in the first 5 years of the consortium, there were 9 centers involved. We now have 19 centers involved. And this enables us to do studies more quickly, to get answers more quickly, but it also allows us to expand access to these clinical trials around the country. So, thank you. So the objectives for this talk, right? So I want to review some clinical trials for a range of NF manifestations. And really, I just want you to understand the basics of the clinical trials. I'm not going to go into the details. You could see how much detail might be needed if we followed Nikki's recipe, which is what you should do if you're going to enroll on a clinical trial. And if you have specific questions and you want more details, just grab me later. I'm happy to talk about any of them. And really what I want you to walk away with is an understanding of the types of targets. In other words, why do we select the drugs that we're testing? All right. And the one thing I just want to point out ahead of time is most of the drugs we're testing are oral. And I just want to say that that doesn't mean they're any less effective than an IV medication. Sometimes people think that if it's not coming IV, it can't work as well, and that's not true. If we can deliver it orally, we'd much rather do that because it's much more convenient to take. And then I want to talk a little bit about where I think we might be heading next. So, excuse me, we're going to start with plexiform neurofibromas and the clinical trials we've done for them. So these are benign peripheral nerve sheath tumors that can cause pain, impair function, can be disfiguring and life-threatening when they compress vital structures. So the consortium has done 3 trials for plexiform neurofibromas. They're all phase 2 studies. One targeted mostly children, and the other 2 are for older adolescents and adults. The reason the age range of these 2 studies is higher is because these 2 drugs, we don't have good information on how safe they are in children. And I want to point out that we're not just enrolling anybody who has a plexiform neurofibroma. So if you have a small plexiform neurofibroma, not growing, not causing symptoms, you would not be a candidate for these clinical trials. What we're focusing on are plexiforms that are growing, causing symptoms or have the potential to cause symptoms and can't be taken out surgically. So in order to understand how we select drugs, you have to understand a little bit about how NF tumors develop. All right, so the NF1 gene product, the protein is neurofibromin. And neurofibromin functions as a negative regulator of a protein called RAS. All right, and RAS is a common protein that's abnormal in many cancers. So now RAS signals through a cascade of other proteins. And at the end of that signaling cascade, it promotes cell division. So one cell becomes 2, becomes 4, becomes 8. So you can imagine that if you're missing neurofibromin and you no longer are putting the brakes on RAS, now you have over-signaling down that pathway and more cell division, and you can see how a tumor might form. And so we're really interested in fixing this process. How do we turn it around, right? We haven't figured out how to add neurofibromin back yet, all right? And so we've tried to target RAS. Can we just have a drug that inhibits RAS? And we've tried that, and unfortunately we haven't been successful at targeting RAS. So the next thing we're doing is we're trying to target downstream effectors of RAS. So if we can't block here, can we block somewhere else along the pathway? And so one way we've tried this is with inhibitors of mTOR, because blocking here may decrease or stop tumor growth. And so we did a trial of sirolimus, which is an mTOR inhibitor. We enrolled, this was the first study that the consortium did. It enrolled 61 subjects, and unfortunately, it did not shrink any tumors. However, there was a modest increase in time to progression. What's that mean? We know from a study that Brigitte Wiedemann did that growing plexiforms, on average, meet our definition of progression in 11.9 months, which means they increase in size by 20%. And this drug slowed down that growth modestly by about 3 to 4 months. So clearly not a home run, but there were not a lot of side effects. And I think where we might be headed with this is trying to understand, is there a subset of patients with plexiform neurofibromas who are more likely to respond? But ultimately, I think this drug is going to end up being combined with another agent. And I'll give examples of that as we move forward. So that's one way to try and damp down this abnormal pathway. Another way we're trying is with a drug that doesn't even have a name yet. It's so new. It's a drug from Pfizer, and it still just has a number. And what it blocks is on this side, it blocks MEK. And we know that MEK inhibitors have resulted in responses in mice with plexiforms, and we know that MEK inhibitors have actually resulted in responses in humans with plexiforms, and I'm going to show you a little bit of that. And so this is an experiment done by Nancy Ratner's lab in Cincinnati, and she has this mouse model that grows plexiforms. And these are called waterfall plots, and I'm going to show you a couple of these throughout, and I'll point out a couple of things. If the bar is going up, the tumor is growing. If the bar is going down, the tumor is shrinking. That's all you need to know when you look at this. So on the left, these are mice that are not treated, and all the tumors are growing. On the right are just this drug at 3 different doses, and you can see now we have some of the tumors starting to shrink. So there was a signal in the mice. We started designing this drug before these results came out, but there's also this trial led by Brigitte Wiedemann at the inside looking at a different MEK inhibitor called sulimetinib from a different drug company in children. The bar of response here is tumor shrinks by at least 20%, and you can see all of these tumors shrinking, and in fact 60% of the tumors met this bar of response. So there's good rationale to pursue a medication like this. So the goal of the trial is to see if we can shrink these tumors. So far we've enrolled 9 subjects. The study is presently halted in enrollment. We're waiting for a signal, meaning at least one of these first 9 has to have a response, bona fide tumor shrinkage for us to expand enrollment, and we're just not there yet. This study opened up barely 6 months ago. So we have another trial, the third trial for plexiforms, and this works on a completely different mechanism. So now, in the first 2 trials, I've been talking about how do you target the tumor cell. Well, a plexiform neurofibroma is made up of multiple cell types. The tumor cell is the Schwann cell. But there are supporting cells in there, one of which is the mast cell. They're actually very important. They they can activate the tumor. And so, for example, mast cells have a protein in them called c-KIT that's overexpressed. And c-KIT causes mast cell activation, which can lead to plexiform tumor growth. So Wade Clapp's lab in Indiana has shown that if you inhibit c-KIT, you can prevent this activation of the mast cells and stop plexiform neurofibroma growth in mice. And so he then did the next logical thing, is he took a known c-KIT inhibitor, imatinib, otherwise known as Gleevec, and did a trial in children, and they had some plexiforms which shrank. Okay, so this drug is different. It's not targeting the tumor cell, it's targeting the mast cell. But it's also targeting something else. It targets angiogenesis. So this is a broad drug. It targets multiple things. So what's angiogenesis? So angiogenesis is the formation of new blood vessels from existing ones. So a tumor can only grow to a very small size without recruiting a blood supply to get oxygen and nutrients so that it can support cell division. All right, and so tumors secrete substances to create this blood supply. So anti-angiogenic therapies are targeting this abnormal blood vessel formation that goes on in tumors. So this study is designed exactly like the last study of the MEK inhibitor, same age range, same patient population. It also has enrolled 9 subjects, and we're also waiting to see if we have a responder before expanding. This study, I think, is about 2 months behind the MEK inhibitor study. So these are the themes, and you'll see them coming up as we talk about other NF manifestations. We're trying to target the molecular abnormalities within the tumor cell. We're trying to target the cells that support the tumor, and we're trying to target this abnormal blood vessel that happens in tumors. Where do I think we're headed for plexiform neurofibromas? Well, we're going to end up, I believe, in drug combination studies in one of 2 fashions. Either using a drug that targets the tumor cell plus a drug that targets these supporting cells, or what I think is more likely to happen sooner is targeting the abnormal molecular pathway with 2 drugs at the same time. For example, let's target mTOR and MEK at the same time, and maybe we'll get a better response. I also think, maybe not in 5 years, but I hope within 10 years, that we will be doing prevention studies. All right, this is not proven, but many of us believe that there's probably a vulnerable window at an early age where if something doesn't happen and you don't form a plexiform, you're not going to form one. Or if you're born with a plexiform, something happens and then it will grow. And if that doesn't happen, it won't grow. And so I think ultimately we're hoping to be able to treat prophylactically young children to prevent either the tumor developing or progressing. You can understand why that's further along, because that would require treating a very young child, and the risks and the unknowns about how a new drug would affect a growing baby is very concerning. So you have to get more data before you head there. All right, so now let's talk about, we've been talking about plexiforms, which are benign peripheral nerve sheath tumors. Let's talk about the malignant ones. And these are much more aggressive tumors, as this audience knows, and very challenging to cure. And so we're already into combinations drug trials with these. And we've done 2 trials, or we're in the process of doing 2 trials, both for inoperable or recurrent high-grade MPNSTs. The first one, actually, they're both collaborations between the NF Clinical Trials Consortium and SARC. What SARC is a consortium of a bunch of hospitals that want to treat sarcomas. And MPNST is considered a type of sarcoma. So we've partnered with SARC, one, to get access for the drugs for our patients, but also to quickly do the trials. So the first one is a combination of everolimus plus bevacizumab. Okay, and you're going to see some common themes here. Everolimus is just another inhibitor of mTOR, okay? And we know that mTOR inhibitors stopped MPNST growth in mouse models, all right? So obvious rationale, target the molecular abnormality. And bevacizumab is an angiogenesis inhibitor, okay? So we've talked about this already as well, right? Vascular endothelial growth factor, or VEGF, is a substance that promotes angiogenesis and is common to this process. And so bevacizumab is an antibody against that. So the goal is to turn off angiogenesis. So we're using these in combination, trying to see if they shrink tumors. This is a phase 2 study, but there was a preliminary phase to evaluate the combination because they hadn't really been tested before. And this study is almost closed. So it's enrolling 25 subjects, it's enrolled 21, and because it's not done, I don't have results yet. The other study that is more recently opened is a study of sirolimus plus a drug called gantenerumab. This is also a collaboration with Sark. Sirolimus we've talked about. Once again, we're taking an mTOR inhibitor and we're combining it with this IV drug, completely different mechanism. This drug inhibits a protein called HSP90. And you can think of HSP90 as sort of this master protein that is important to regulate other proteins that enable tumor cells to survive, grow, and spread. So we want to shut down the master protein to prevent the tumor cells from doing that. And the preliminary work out of this comes from Karen Chkowski's lab in Boston. The preliminary work provides great rationale for doing this. Once again, we're back to these waterfall plots. So here, no treatment, all the tumors are growing. Here in the mice, she treated just with the HSP90 inhibitor. It looks like she probably slowed tumor growth, but nothing great. Here she treated just with the mTOR inhibitor, and it looks like she stopped tumor growth. But still, each single drug, no responders, no tumor shrinkage. We want to shrink tumors. But lo and behold, when you put them together, you get this synergistic effect, and now tumors are shrinking. And this is just an example of a tumor, 10 days of the combination, it shrunk. And this was the first combination that she had that actually shrank the tumors in the mice. So really good rationale and preclinical data for moving forward with this. This is a phase 1/2 study. So if you remember what Nikki was saying, the phase 1 portion is we need to know the best dose. This is a very new drug. What is the best dose of gantenerumab, and what's the safety of putting them together? And then obviously we want to know, does it shrink tumors? So the phase 1 portion is actually over. And we are going to be starting the phase 2 portion probably within the next month, and that's going to enroll about 20 subjects. So let's shift to talk about low-grade gliomas. So these are brain tumors that occur in NF1, most commonly in the optic pathway, and they can cause vision loss and other problems. At least for this tumor, we have a reasonable standard therapy, but you can see it only stops about 2/3 of the tumors from growing. So 1/3 it doesn't work for, and of this 2/3, it doesn't work forever. Sometimes some of them grow. So we're really searching for other options and better options. And so the consortium has 2 trials. One we've completed and one we're just starting for recurrent low-grade gliomas. Because we have a standard therapy, we feel that patients should get the standard therapy before engaging in a clinical trial for this tumor type. So the first study was that drug everolimus again. And you know, a lot of our early studies were focused on this first target that we found in NF tumors. And one of the other reasons we chose this mTOR inhibitor is that it was already FDA approved for a tumor called subependymal giant cell astrocytoma, which is just a type, yeah, it's a big word. It's just a type of low-grade glioma that occurs in patients with the genetic disease tuberous sclerosis. All right, so there was good rationale to use it. This was for children who had failed initial therapy. This study enrolled 23 subjects and is closed. And I don't have results, but I know that the study team is furiously working at analyzing those results with the hopes of presenting them at June at the CTF's annual NF conference. So we hope to have results on this for everybody by June. The other study we're just launching, and it's a study of, another MEK inhibitor from yet another drug company, okay? And why we choose one over the other is a discussion for another time. But once again, you can understand the rationale for doing this. This is now a collaboration between 8 of the NF consortium centers and 8 centers not in the NF consortium but of expertise in brain tumors. Once again, we're trying to, we basically, came to them and said, we really need a MEK inhibitor for our patients, and the goal here was to expand access more than anything. This is also a phase 1/2 study. So there'll be a phase 1 portion where they determine the best dose, and then there'll be a phase 2 portion, and the goal is to enroll 18 patients with NF1-associated low-grade gliomas. Once again, I think where we're headed with this tumor type is going to be combination studies at some point once we learn more about the safety and the effects of using single agents. But in addition, I think for this tumor type, what we really need is a better identification of who needs treatment. All right, so no more than half of patients with NF1-associated optic pathway gliomas will ever need treatment, because no more than half of them will ever have tumor growth, or the tumor won't affect vision. And so that puts us in a quandary when we have a patient with a newly diagnosed optic pathway glioma, right? Do we treat that patient? Do we not treat that patient? We don't want to give someone therapy that they don't need. All right? And right now, we don't know how to figure that out. And the good news is Children's Tumor Foundation is funding a very large prospective study that's going to enroll 250 NF1 patients with newly diagnosed optic pathway gliomas. And so I hope that in about 5 years, we'll be able to let you know at diagnosis which optic pathway gliomas are high risk or not. All right, let's shift to NF2 and talk about vestibular schwannomas for a second. All right, there are definitely standard treatments, but the standard treatments clearly have risks, and I'm sure Dr. Plotkin will talk more about that in his upcoming talk this afternoon. The consortium is one trial right now for vestibular schwannomas, and here's that drug again, bevacizumab, right? We know that vestibular schwannomas express vascular endothelial growth factor, so we're going to target it and try and shut off this abnormal blood vessel formation. And Dr. Plotkin did a small study in which he showed that half of the patients had hearing improvement and another quarter hearing stability on this drug. And so he then brought this idea to the consortium, and he's leading the study. And so we're doing bevacizumab with the goal of, does it improve hearing? All right, so we're not just interested, does the tumor shrink? We want to improve function. We're looking at quality of life. I'll tell you that most of our studies also look at quality of life as well. We want to know that we're not just shrinking a tumor, but that we're improving the quality of life for patients. Right now, it's enrolling patients that are 12 to 40 years old, although we hope that we may be able to expand that age range, that have vestibular schwannomas that either can't be resected or the patient decides they don't want surgery, that are associated with hearing impairment, defined by the word recognition score, and that have documented clinical progression in the prior 18 months. And we're hoping to enroll 24 patients. We've only enrolled 7 so far, so we're really early as far as enrollment goes. All right, so let's shift out of tumors. Let's talk about cognition for a second. All right, so Dr. Walsh talked to you this morning about cognition, is going to talk probably more in depth about clinical trials this afternoon. But over half of children with NF1 have learning and attention problems. So one of the consortium's early studies was we called STARS. And this was a double-blind, placebo-controlled study of lovastatin. All right, so Nikki's told us what a placebo is. She's told us what randomization is. I don't know if she discussed double blinding, but I'll just let you know what that means is the patient doesn't know what they're getting, or the parent of the patient doesn't know what they're getting, and the treating physician doesn't know what you're getting either. Why did we do this study? Well, there was mouse evidence that lovastatin can decrease RAS activity in NF1 mice, and that it can improve the performance of NF1 mice on tests of attention and spatial learning. And yes, you can test a mouse's attention and spatial learning. It's quite shocking. And you probably know this drug because it's a common drug to lower cholesterol. So the goal of this study was, did lovastatin improve visual spatial learning or sustained attention in children with NF1? So you had to be impaired on a particular measure of one of these things to be eligible to enroll. If you weren't impaired, you couldn't improve on the drug. This study enrolled 146 patients, right? Half getting placebo, half getting drug. The study's closed, and like the low-grade glioma trial I mentioned to you, the study team is furiously analyzing results with the hope to present them to us in June. So hopefully we'll have an answer in 2 months about whether this worked or not. All right, last manifestation we're going to talk about is tibial pseudoarthrosis, which is the thinning of the long bones caused by deficient bone formation. In this setting, we are not targeting the molecular abnormalities going on in the tumor. We're not targeting the biology of the tumor or the manifestation of NF. All right, what we're looking at is, can we improve bone healing? All right, so this is using something called infused bone graft. All right, what infused bone graft is a sponge that's infused with bone morphogenetic protein. And what that is a protein that stimulates bone formation. So the concept here is, can you apply it to the bone at the time of surgery and improve or quicken bone healing? So I excuse the more graphic photo right after lunch, but I think this really explains it all. All patients will get standard surgical treatment, which is resect the abnormal pseudoarthrosis tissue, place a rod, do a bone graft, and half of them will get this sponge wrapped around the bone graft. All right, and then we will see, did the group that get the sponge have better, quicker bone healing than the group that got the standard therapy? So enrolling children who are at the time of their first or second surgery, 50 patients will enroll, 25 per group. This is approved but not yet open at sites, but hopefully within the next couple of months. This is also a study where we've added sites outside of the consortium because this is a pretty rare manifestation. So just to summarize, really, the last 5 or 10 years, we've had a tremendous increase in our understanding of the biology of the manifestations of NF, and this really has fueled the development of the clinical trials we're doing. And we're really focused on targeting molecular abnormalities that we're identifying. And in addition to tumor control, we're also interested in functional outcomes and quality of life. In general, where I think we're headed is we need better identification of who needs treatment, and I think we're heading that way. We still need better drugs. I'm hopeful in a longer time frame that we'll have prevention strategies, but in a shorter time frame, I think we're going to be doing combination studies where we're adding 2 drugs that target different areas on this pathway, sort of doubling down in our ability to turn off this abnormal pathway. So I'll stop. I'm happy to take questions. I'll leave this slide up, which lists all the consortium sites in case you want to find a site near you.